Hello, followers of Neuro Takeaway. Today we're going to speak about one of the most frequent complaints of our patients, visual problems. The title of this conference is Hi Doc, I'm not seeing well and it hurts. I'd like to thank the pharmaceutical company RAFO for the support for this conference. Okay, let's kick off. First of all, we are going to talk about technical considerations, the artifacts. In the orbit, we use very frequently fat-SAT sequences, which are susceptible to a lot of artifacts, especially at the boundary between the maxillary sinus and the floor of the orbit. So we have to be careful. Sometimes the saturation of fat is asymmetrical, and it could be, you can find these hyperintensities on T2 fat-SAT, which are seen in every plane, so we have to take them with caution. Speaking about measurements, we should know that, for example, when we want to measure the optic nerve or perineural sheath complex, we have to do it in a perpendicular plane to the long axis of the optic nerve. For example, in this case, it is properly done and it is 4.8 millimeters, which is within normal limits. The limit is 5 millimeters. In this case, we are using a wrong plane, a coronal plane to the brain, but not to the long axis of the optic nerve, and it is beyond normal limits, and it's a wrong measurement. This optic nerve has its tortuosity, especially on the axial plane, so we have to be careful. It's very difficult to pick up the whole length of the nerve in the sagittal plane, and we don't have to take these irregularities on the sagittal plane as alterations. We have to look at the other planes. Here we have the gadolinium enhancement. In the orbit, we have several structures that enhance a lot with the gadolinium, as the extraocular muscles, which are very vascularized. For example, the lacrimal glands, the pituitary stalk, and some vessels. And speaking about vessels, we have to know that some little veins sometimes surround the optic nerve at the level of the apex, and we don't have to get these structures as abnormal enhancement of the nerve. Special sequences. We use some special sequences to study the orbit. For example, the diffusion. We use here non-epi diffusion weighted images, which are susceptible of less artifacts than the usual sequence for the brain. And finally, when we want to study the globes, we require some dedicated coils, which are small coils that adapt very well to this region and produce these fantastic images. Okay, let's talk about some, let's say, incidental findings in quotations. Here we have this little calcification at the level of the head of the optic nerve. It is drusen. They are usually asymptomatic, but they can produce pseudo-edema of the papilla under the fundoscopic examination, so it's very important for us to report them. They are due to the position of mucopolysaccharides and mucoproteins at that level, because there are several theories, but One of them says that they are due to a remnant of the exoplasmic flux at this level. Here we have two pretty symmetrical calcifications at the posterior wall of the globes, and in this case they are due to calcifications of the tendinous insertions of the extraocular muscles. In this case, again, two fairly symmetrical calcifications in the supranasal angles of the orbits, and they are due to calcifications or degeneration of the trochlear of the superior oblique muscles, which are very frequently found in the elderly. On MR, we usually, many times we find these images. They are due to surgery of the lens because of cataracts. We don't find the lens, we find these prosthesis, and this is called pseudophakia. And finally, these large globes with some thinning of the wall, which is called staphyloma, are due to myopia. They are usually asymptomatic, but sometimes they can produce what is called the heavy globe syndrome, because these huge globes may compress the extraocular muscles and produce diplopia. Okay, we have two optic nerves, and we have to look at the symmetry of these structures. Here we can see a patient with MS, which came for a control study, and we can see the thinning of the left optic nerve with dilation of the perioptic sheath. And this is typical of optic nerve atrophy, which we have to differentiate from optic nerve hypoplasia, in which there is no dilation of the perioptic nerve sheath. Let's go to some pathologies. We have always have to search for trauma. This is a 3-year-old girl with blue tears. We performed a CT and we found this small hyperdense structure at the nasal half of the orbit, surrounded by soft tissue. This is associated with a fracture of the roof of the orbit, a contusion at the frontal-basal supraadjacent level. We can see the enlargement and swelling of the soft tissue of that side. Because there was no metal, we decided to go to MR. We can see here this structure is hypointense on T2. We can see the contusion at the frontal basal level. And again, this structure is surrounded by soft tissue, probably hematoma or inflammation. And going back and trying to understand this case, the history was that this girl was running, grabbing a pencil. She fell over and she stabbed this blue pencil, in her eye. Some part of this graphite remained in her eye, and that's why she had blue tears. Okay, we have always to check the bone window thoroughly. This is a 28-year-old man with decreased vision and dyschromatopsia in his left eye after a blunt orbital trauma. In this case, we found enhancement and enlargement of the intra-optic canal segment of the left optic nerve. It has a high perintensity on stir. It is associated at the CT with a little fracture, a little fissure at the level of the lateral wall of the optic canal. This is called the traumatic optic neuropathy. These patients may have this visual loss in spite of not having any bone structure inside the canal. If we found some bone fragment at this level, obviously this patient will go to surgery, but in most cases we don't, and they are treated with steroids. It is like a shock of the optic nerve. Okay, this is a 16-year-old male with headache, blurred vision, and mental confusion. You can see these hyperintensities both at the infratentorial and supratentorial white matter without mass effect. They are typical of demyelination, and at the same time we can see the symmetrical enlargement and enhancement of the optic nerves. This is a typical case of ADEM. Now we can say that ADEM is like an umbrella term that we have a lot of demyelinating acquired syndromes. We can divide them in monophasic and then are again divided if the patient has encephalopathy or not. If there is encephalopathy, it is an ADEM, which in pediatric especially is almost always associated with anti-MOG antibodies. And if there is no encephalopathy, it's like a clinical isolated syndrome, which is associated with MS. And one of these syndromes is optic neuritis. On the other hand, we have the multiphasic variant. It can be MS, it can be anti-MOG or anti-aquaporin 4 antibody-related NMO. In each of these entities, we can find optic neuritis, and we see that anti-MOG is probably the most frequently associated with this alteration. Here we have a 19-year-old woman with frontal-orbital headache and blurred vision on the right side. You can see this enlargement and hyperintensity on T2 fat SAT on the right side, and enhancement of the right optic nerve, especially in the interorbital segment. This enhancement is not limited to the nerve. It goes, it compromises the periorbital fat. Here we can see that on the coronal with the dirty fat SAT, retrobulbar fat, and there is no compromise of the optic chiasm. Well, this was positive for anti-MOG antibodies, and this entity may be bilateral and simultaneous in many cases. We have to check the contralateral normal side, especially for atrophy. The compromise is most important at the retrobulbar segment of the nerve with papillitis. There is a spare of the optic chiasm. There is inflammation both of the nerve and the perineural fat, and in general there is good clinical recovery in 80 to 90% of cases. Here we have bilateral optic nerve atrophy, as we can see on these actual images, and they are associated to demyelinating supratentorial lesions. And I put this case to remind you that we always have to look at the nerves. In children, sometimes there is no history of visual loss, and this optic nerve atrophy is very frequently associated with anti-MOG. It can always get worse. This was a patient, an 11-year-old boy with anti-MOG antibodies and recurrent bilateral optic nerve optic neuritis. This is very, very common. Here you have in May 2014, this patient came with atrophy of both optic nerves, but in December of the same year, he came back with impairment of his vision, and you can see this enhancement and enlargement of both optic nerves. This is a recurrence of this entity, which is very common. Well, this is a classic. This is a 27-year-old woman with unilateral subacute loss of vision and right retrobulbar pain. You can see this enhancement at a segment of the intraorbital portion of the right optic nerve. There is, you can see the enhancement on the coronals, and it is associated with typical demyelinating lesions in the white matter of the brain. This is positive for the or fulfill the McDonald criteria for MS. I remind you that the optic nerve is not between these criteria so far. And well, this is a classic. We have the good, the bad, and the ugly. And the ugly is NMOSD. Here we have a 45-year-old woman with bilateral loss of vision and right hemiparesis. There is enlargement of both intracranial segments of the optic nerves. There is enhancement, especially on the right side, and it is associated with a very large white matter lesion without a lot of mass effect and with a typical cloudy enhancement on the left side. And there is also myelitis, long extended, longitudinally long extended lesion with some bright spots typical of this NMO spectral disorder. Okay, comparing the big three, anti-MOG, NMO, and MS, especially regarding the optic neuritis, we can say that anti-MOG is the most commonly associated with this entity in 60 to 74% of cases, NMO in 45%, and in MS around between 15 and 20%. And look at this in anti-MOG, the bilaterality is very common in 35 to 41%. In MS, it's very rare. And just to underline that in 1/3 of the adult patients with anti-MOG antibodies, there is a fulfillment of the 2017 McDonald criteria for MS at some point of their evolution, and this is important because it reminds us that these criteria are not useful for the differential diagnosis. Well, these rules, as every rule, can fail. This was a case of our hospital. It was published by Sylvia Tenenbaum. This is a 4-year-old boy with a first attack of ADEM. You can see these typical hyperintensities at the subcortical white matter, at the basal nuclei, and he did well with the steroids, but he came back 4 months later. And when I saw these images, you can see the resolution of the white matter lesions, but there is another lesion at the level of the chiasm and the optic tracts. Well, I suspected an anti-aquaporin 4 antibody-related demyelination, but it turned out to be anti-MOG. So sometimes the rules fail. Here we have another case. Not everything is demyelination. This was an 8-year-old boy with right visual loss, orbital pain, and eosinophilia. There is a lesion at the level of the head of the right optic nerve and the surrounding retina. There is enhancing there. This is the head of the nerve, enlarged and with enhancement. And under the fundoscopic examination, you can see this typical image of a macular star. This is a case of Bartonella neuroretinitis, which is very frequently found in children. In the other end of life, this is a 78-year-old woman with history of headache, fatigue, jaw pain, and visual loss. In the lab, we found an increase of ESR, and she was admitted for left side hemiparesis and confusion. You can see here this typical image of a stroke in evolution in the acute phase. When we performed the MRA, there was no striking alterations intracranially, but we found there is no signal intensity, poor signal intensity in both external carotid arteries, especially in the superficial temporal arteries, especially on the left. So because of the suspicion of temporal arteritis, DCA was performed, and we confirmed this irregularity of the superficial temporal artery. And after steroid treatment, the signal intensity on MRA came back. Well, this is a very well-known entity. You know that we have the ischemic optic neuritis or neuropathies. They can be anterior or posterior. Anterior are more frequent, and inside these lesions we have the arteritic variant, which are not the more frequent, but when we found them, they are usually caused by this giant cell arteritis. There are some publications about the utility of vessel wall imaging with black blood sequences without and with gadolinium to show this concentrical enhancement of the ophthalmic artery, which is typical of this entity. Just to remind you, the complex vascularization of this region, we have the central artery of the retina, we have the posterior ciliary artery with the long and the short ciliary arteries, we have the Singer circle surrounding the papilla, and there is an important anatomical relation between the cap and the disc of the papilla. When this relation is small, there is like a risk factor for an ischemic complication. The optic chiasm may be inflamed as well. Here we have a 47-year-old woman with headache, progressive visual loss, and diplopia. We can see at the basal study the lesion at the level of the chiasm, the optic tracts, the posterior frontal basal region, the superficial boundaries of the mesencephalon, the hypothalamus, the posterior limbs of the internal capsules, and there is enhancement at these levels. There is like a peripheral enhancement of the optic tracts, the superficial, the surface of the mesencephalon. After steroid treatment, there is a marked increase in the restoration of these alterations. There is just a little enlargement of the optic tracts left. Well, this case was sarcoidosis. Sarcoidosis is a rare disease, but when we rule out everything, we can think of this entity. And in this case, it was confirmed by biopsy. We found the typical non-tuberculous granulomatous process. There are other structures that can be inflamed as the cranial nerves. This is an 11-year-old girl with migraine, headache, and left third cranial nerve palsy. Here we have the clinical examination of this girl with the typical ptosis and exotropia of the eye. And when we studied her, we found enlargement and enhancement of the cisternal segment of the third nerve, of the left third nerve. There was no alteration at the MRA, and this was a case that you can call it ophthalmoplegic migraine or isolated cranial neuritis. There is no consensus about this yet, but beyond the nomenclature, we can say that we have to check the cisternal segments of these cranial nerves to rule out this process. And it's very easy when we perform very thin slices with GAD. Well, we have to look at the whole picture. In this case, we have a 65-year-old woman with ocular pain, horizontal diplopia, and renal failure. At the lab, she had ANCA C positive, and we found this tissue at the lateral wall of the orbit that is engulfing the lateral rectus muscle. And when we look at the mucosa of the nasal fossa, we found these gaps in enhancement, which are typical of this process. It represents the necrosis of this mucosa, and this is typical of the granulomatosis with polyangiitis, which we used to call Wegener granulomatosis. Sometimes the key is the cerebellum. This is a case of a young boy with subtle visual alteration on the right side. We studied him in 2017, and we found this small enhanced lesion at the level of the papilla. They decided to control him, and in 2018 he developed a retinal detachment, and 1 year later this lesion, the detachment resolved partially, and the lesion increased in size a little bit. On the first examination, we found these lesions at the level of the cerebellum, which are typical for hemangioblastomas, and this was a case of retinal hemangioblastoma associated with von Hippel-Lindau disease. And I take advantage of this case to remind you that there are different kinds of detachments. This is the typical V-shaped detachment of the retina. This is the lenticular detachment of the choroidal membrane, and this is fluid accumulations beyond or besides the vitreous. Sometimes the problem is at the choroidal membrane. This is a 51-year-old woman with a right-eye visual field defect. And when we studied her, we found this small, spontaneously hyperintense nodule in her right globe. There was no enhancement. The lesion was hypointense on T2, and this was, as you can think, a choroidal melanoma. These choroidal melanoma are usually diagnosed by our colleagues, the ophthalmologists, through the echography, ultrasonography. The typical shape of the mushroom is very, very typical of this lesion. It is usually asymptomatic. It may be an incidental finding, but it's very important to pick it up because it is a malignant lesion. Okay, we have to always to search for the skin, look at the skin, call our colleagues, because this was an 48-year-old woman with diplopia and history of thigh cutaneous melanoma with growing mets. Melanoma loves the orbits, and here we have a lesion at the level of the left lacrimal gland, which is enlarged, is hypointense on T2, relatively isointense on T1, but there is restriction and enhancement, and this was met from this melanoma. In this case, there was no spontaneous hyperintense intensity because this was an amelanotic melanoma, which is not so rare. In 20% of cases, there is no melanin in this tumor. Sometimes the problem is pressure on the optic nerve. This was a 45-year-old woman with headache, pulsatile tinnitus, and visual loss over the last 3 months. You can see this enlargement of the perineural sheaths and the protrusion of the optic heads to the vitreous. There is an empty cella, enlargement of the trigeminal cisterns, the empty cella on the sagittal, and there is a thinning of the lateral portion of the transverse venous sinus. As you know, this is the typical findings of an idiopathic, in quotations, intracranial hypertension. Why in quotations? Because we have to rule out an underlying process. The last case I had the opportunity to diagnose was 1 month ago. It was a case secondary to polycythemia vera with a slow flow, very slow flow, a sluggish flow at the level of the superior sagittal sinus. Now we know that in this entity we can find restricted diffusion at the level of the heads of the optic nerves, which they can enhance as well. We don't have to take enlargement for inflammation. This is a 4-year-old girl with progressive right exophthalmos, and there is a marked enlargement of the right optic nerve in all its length, both intra and extra cranially, and there is a remodelation of the optic canal, which means long duration of this process. The signal intensity is isointense on T1 and T2. In this case, there was no enhancement. In this entity may enhance in 50% of cases, and as you may suspect, this is an optic nerve glioma. This entity is associated with NF1 in 50% of cases. The majority are pilocytic astrocytomas, and most of them are asymptomatic. We don't have to take enhancement regression for inflammation. This was a case of NF1, an NF1 patient This girl came with for a control study when she was 8 years old, and we found this enhancement at the level of the intracranial portion of the right optic nerve. And you can see here very clearly on the action. And she came back many years later when she was 40. And you can see the resolution of the enhancement. This was without treatment, and it's very frequently found in these uh, optic gliomas, especially in the context of NF1, this kind of spontaneous resolution of the enhancement or changes in the size of the tumor. Well, neural or perineural, and this is a dilemma that we have to resolve as neuroradiologists. Here is a 53-year-old woman with progressive right exophthalmos. And you can see this mass, and it is associated with enhancement of the perineural area of the right optic nerve. On the corona, we can see this typical peripheral enhancement of the right optic nerve, and this was a case of an optic nerve sheath meningioma. In this companion case, we have calcifications on both optic nerves, especially on the left side. And look at the MR, you can see this typical tram track sign, typical of meningioma, in this case, bilateral. Well, there is not just one nerve in the orbit. This was a case of a 42-year-old woman with mild left exophthalmos, diplopia, and retroorbital pain. And you can see this nodule very well defined at the roof of the left orbit. It is isodense on CT. It enhanced a lot with gadolinium. And you can see this typical target sign. And this was a case of an orbital schwannoma in the context of schwannomatosis. This sign is more typical for neurofibromas, but it can also be found in schwannomas. What to think in pediatrics? Well, there are a lot of lesions here, but I want to remind you this one because it is a malignant tumor. It is the most frequent malignant tumor in the orbit in pediatrics, especially during infancy. It is associated with leukocoria, and it is the retinoblastoma. It can be uni or bilateral. In this case, we have bilateral lesions. You can see this nodule on the left eye, which have a restriction on diffusion. But on the right side, we have this typical pattern of retinal detachment. But when we administered gadolinium, we can find these areas of enhancement which are associated with restriction on diffusion. And this is the typical pattern of this tumor. This tumor is associated with calcifications which are seen bright on the face variant of the SWI and hypointense on T2. Well, just to remind you that there are other entities like PHPV, Coats disease, toxocariasis, astrocytic hamartomas, and medulloepitheliomas. We are not going to go to them because of time issues. What to think of in pediatrics? Well, there are many other tumors in the orbit. I just put it 4 cases because they are very frequent. Here we have a lesion at the level of the pterion with protrusion to the orbit. It is like a high cellular process with restriction on diffusion, with enhancement. There is enhancement of the dura mater of the middle fossa, and this was a mets of neuroblastoma I don't know why, but neuroblastoma loves deuterium. We can see sometimes bilateral lesions at this level, and this is a neuroblastoma case. In this other case, we found a huge mass at the retrobulbar, intra and extracornal regions of the right orbit. There is an enhancing lesion with slight restriction and diffusion, and it is a rhabdomyosarcoma, which is very frequent in the orbit. It's the most frequent malignant mass of the orbit out of the globe, and in most of cases it is embryonal variant. Here we have a lesion at the level of the eyelid. This is a lesion that enhances a lot with gadolinium, and it is associated with the small vermicular areas with flow void, which are vessels, and this is, as you can suspect, an hemangioma. Hemangiomas can be congenitals, which may involute very rapidly. We call them rich, or they can be non-rich variants. And we have the infantile variants of hemangiomas, which are like another pathologist because they are GLUT1 associated lesions. And this was a congenital case with spontaneous involution. And finally, these lesions that are located usually at the lateral walls of the orbit, they are benign, they are hyperintense on T2, sometimes they are usually hypointense on T1, sometimes with some spontaneous hyperintense areas of fat content. And in this case, there is restriction, and they are, as you can suspect, an epidermoid lesion. Okay, let's talk about infections. Well, this area is very vulnerable for the progression of superficial infections. In this case, we have a furuncle in the superior eyelid, and in the orbit, you can see the enlargement, swelling of the soft tissues of the left side of the face, the temporal region, and there is spreading to the orbit with enlargement of the muscles, the retrobulbar fat. All these lesions are hyperintense on T2 fat SAT sequences. You can depict this abnormal pattern of enhancement of the left cavernous sinus, which means thrombosis. The coronal slices with GAD are the best way to see this cavernous sinus thrombosis, and it is associated with enhancement of the subarachnoid spaces of the left temporal lobe and areas of infarctions of the left hemisphere, cerebral hemisphere, that are secondary to ICA vasculitis. So this was a case of Staphylococcus aureus cellulitis, and just to remind you, there is a classification, the Chandler classification, to understand this process that can go from a type 1 to a type 5. In this case, this is a type 5 type because of there is compromise of the cavernous sinus, which is the worst type. Sometimes the viral infections may be complicated in this area. This is a case of an 81-year-old man with cutaneous vesicles and scabs and swelling on the first division of the right trigeminal nerve dermatoma. On MR, we can see the enlargement and exophthalmos of the soft tissue of both of the superficial subcutaneous tissues and the orbit, and this funny pattern of enhancement in the orbit at the perineural level and at the level of the muscles. And this had been reported in herpes zoster infections. We have to be aware of this because this infection may be kind of dangerous in some cases. A companion case of VCV ophthalmicus infection, but in this case there is another finding. There is some kind of collections in the left orbit. These collections, which are usually associated with restriction, and in this case they are associated with thrombophlebitis of the superior orbital vein, are typical of a bacterial superimposed infection of the orbit. Well, the anterior compartment of the orbit is usually studied by the ophthalmologists through ultrasonography and clinical examination. But sometimes we have to study cases of this entity. You can see here a boy with a bright area in the clinical examination. This is a dependent bright spot. On MR, we see the hyperintensity at the anterior camera, and there is enhancement at this level. There is restriction, and this is a typical case of hypopion. Hypopion is purulent content in the anterior compartment of the eye, and in this case, it is associated, as usually, with enlargement of the iris and the ciliary processes. Well, just to remind you, we don't have to get confused within these terms. The anterior compartment of the eye has the anterior chamber, which is in front of, anterior to the ciliary process and the iris, and the posterior chamber, which is beyond that. It is a very, very small space. And the vitreous is not the posterior chamber, it's the posterior compartment of the eye. Okay, what to think in adults when they come with this painless exophthalmos and diplopia on one side? We have to think about this entity because it's the most frequent tumor of the orbit in adults. It is a lesion, very well-defined lesion. It is hyperintense on T2 fat SAT. It can be associated with a small cyst. There is not much restriction and diffusion, on the contrary, and there is marked enhancement. And as you can think, this is a typical image of venous malformation, which previously called a cavernous hemangioma. Now we use the Mullen classification, Mulliken classification, and we know that this is not a hemangioma, this is a venous malformation. Well, hormones and orbits are related, as you know. This is a typical case of thyroid-associated orbitopathy. The face of the patient is very well known. There is bilateral exophthalmos and inflammation of the conjunctivitis. Here we have the images of bilateral enlargement of the extraocular muscles, especially at the bellies. And in the acute phase, it can be associated with a hyperintensity on T2 fat SAT, and in the chronic phase, it can be associated with lipid content of the muscles. There is enlargement as well of the retrobulbar fat, which can compress the septum, and this is most marked in the medial and inferior extraocular muscles. Here we have another case of a 57-year-old man with right frontal orbital headache, visual blurring, and a slight exophthalmos. And this is a pseudotumoral lesion. And you can see here this area of enhancement at the apex of the right orbit, and this is there is like an spread into the anterior part of the cavernous sinus, and the superior fissure, orbital fissure. This tissue is hypointense on T2, and this is a case of idiopathic, quote unquote, orbital inflammatory disease. I said this idiopathic in quotations because we always have to rule out IgG4 that now that we can check it, we find it very frequently, and it is a chronic disease that should be treated with immunosuppression. This inflammatory pseudotumor may have several phases. You have the diffuse variant, the myositic one, dacryoadenitis, episcleritis, and in this case, perineuritis. It is usually painless. This is another case. This is a 15-year-old male with orbital pain and and diplopia. And you can see here the compromise of the third cranial nerve, and there is a tissue at the level of the left cavernous sinus, which enhances with gadolinium, and there is no restriction. And this is a typical case of what is called as Tolosa-Hunt syndrome. It is, in contrary to the last entity, it is associated with pain, and there is like an inflammatory granulomatous tissue that responds very well to steroid treatment. Well, sometimes we have to diagnose between a tumor or a pseudotumor, and this is a difficult task for us. Now we have the diffusion. This is on the left side, we have a case of a lesion at the level of the lacrimal gland. This is, there is like a isointense on T2, but with a lot of restriction on diffusion. And this is another case with no restriction. This was a lymphoma, this was dacryoadenitis, but sometimes it is difficult to differentiate these two entities, and I recommend that you read this paper of one of our colleagues, Francisco Maldonado, which will be published in Pediatric Radiology soon, about the utility of ADC to differentiate benign and malignant lesions of the orbit. Well, what about the vessels? There are a lot of pathology of the vessels inside or around the orbit. I will just show you 3 cases. This is a 78-year-old male with intermittent exophthalmos, and we found this typical varix at the roof of the right orbit, but below the superior rectus. And this is the location of the superior orbital vein, as you know, and this is a typical clinical syndrome with an intermittent exophthalmos because it enlarged and engorged in association with Valsalva maneuvers. This is a 35-year-old woman with proptosis and chemosis on the left orbit, and you can see this funny pattern at the level of the left cavernous sinus. And when we performed the MRA, we found this irregularity at the level of the ICA, and this was, as you can think, carotid, cavernous carotid fistula which may be spontaneous or secondary to trauma. And the third case is a 54-year-old woman with aneurysmal subarachnoid hemorrhage. You can see the hemorrhage, the association with intraventricular hemorrhage. This was secondary to rupture of this aneurysm at the level of the anterior communicating artery complex. There were other aneurysms malformations here. But what I want to show you is these funny hyperdensities at the level of the perioptic neural space, and this is called the Terson syndrome. This was associated with vitreal hemorrhages under the fundoscopic examination, and this is due to spreading of blood through the perineural space all the way through the orbit. And it is a very not so rare syndrome. We have to look at it. Well, as you know, sometimes the problem is at the back, and we have to suspect this when the patient come with a homonymous hemianopsia. We know that this is due to a retrochiasmatic lesion. In this case, there is an infarction, a stroke, acute stroke at the level of the posterior cerebral artery. The CTA was normal because in these cases of cardioembolism, they are usually associated with spontaneous recanalization. And finally, I'd like to show you this case. This is an 84-year-old man with diplopia, and this entity was recently described. It is called the sagging eye syndrome, and it is the most frequent cause of diplopia in the elderly. There is like a sagging eye on the right side here. If you put this line through the lateral rectus, you can see that on the right side there is like a drop of the muscle, and this is due to degeneration of this ligament that goes from the lateral rectus to the superior rectus, and it is like very frequent in the elderly. Well, just to conclude, as usual, we have to know the anatomy, to master the pathology, use the right sequences, and put all of them in context. And I want to show you this picture of this painter, Alice Garant. She's a Canadian painter, and she loves to draw these, I would say, unsettling images of faces with these eyes that makes you feel dizzy, as most of our patients feel. Well, thank you very much for your attention, and I can answer your questions on the channel.